In today's session, we want to look at antiretroviral drug therapy. This is a type of antiviral drugs, but specifically in this session, we are going to look at drugs used to treat HIV-1 and HIV-2. And as we begin, we always remind you to subscribe, like the video, and share to many others, so that we may continue to make more videos like this. So we are going to remind ourselves the structure of the virus of HIV virus. How does it replicate in the host cell? Then afterwards we shall look at different classes and we shall end up with HAT, or how do we combine these HAT drugs for better treatment of our patient. Let us get started. So we are seeing the structure of a virus. This is the structure of HIV virus, which is divided into HIV-1 and HIV-2, whereby HIV-2 is common in West Africa. So for us, we are going to see which drugs do we use to treat patients who are having HIV. And first of all, HIV is an enveloped virus with RNA. So the genome is RNA. And this envelope of the HIV virus, the coating has what we call the glycoproteins, whereby we have glycoprotein 120, which is the base of the spike. Then the long arm is known as glycoprotein 41. Then inside the core or the capsid, we have glycoprotein 24. Then we have the RNA genome together with integrase enzyme and protease. So the HIV virus comes well equipped with all these guys to enable it enter the cell and survive, so that it can replicate, form more copies of the virion to attack new cells within the CD4. So we're going to see this HIV virus. How does it enter into host CD4 cell? So this is a CD4 positive cell. And when this virus comes, it attaches on the receptor using its spike, whereby we have seen it attaches using glycoprotein 120. It has the spike, whereby the spike we have seen this, it is using glycoprotein 120 and glycoprotein 41 to bind to the receptors of the CD4 in the host cell, because we know these viruses, they can only replicate in the host cell. So when it binds, remember its genome is the RNA containing glycoprotein 24. So when it binds, the attachment is not firm. So there is what we call a co-receptor present. And the co-receptor which is present is known as chemokine receptors. These receptors, these are known as the co-receptors. And these co-receptors, we can name it, we have CCR5 and CCXR4. CXCR4. So these are the chemokine receptors which act as the co-receptors for firm attachment of the HIV virus, so that it can fuse to enter into the cell. So with help of this HIV virus is able to enter by endocytosis or pinocytosis, and it is able to enter into the host cell. And when the virus enters into the host cell, it uncoats. When it has entered, it is going to uncoat. Remember, it has the genome in the form of RNA, so it uncoats to release the genome. And we said this genome in the HIV virus is RNA. So this RNA is released. So this is the viral RNA, which is released by the process of uncoating. Remember, it also had the protease and the integrase enzyme. So after being released, we have to first convert it into the DNA. So how do we convert it? We are going to see viral RNA being converted to DNA, whereby we use the viral RNA as the template to form the viral DNA. Yeah, we're able to form the viral DNA. And which enzyme is responsible for this is known as reverse transcriptase enzyme. So in the presence of reverse transcriptase enzyme, it is able to convert the viral RNA into double-stranded DNA. And remember, in the cell, we always have the nucleus, and within the nucleus, we have also the host DNA. We have the host DNA. So this is the DNA of the host. So what happens after forming the HIV double-stranded DNA? It enters via the nuclear pore into the nucleus of the host cell. And when it enters, with the help of enzyme integrase, this enzyme integrase, it cuts in the middle of the host DNA and incorporates the viral DNA. It comes and incorporates the viral DNA. So the enzyme that is catalyzing the incorporation of the viral DNA into the host cell DNA is what we call integrase enzyme. So this is the viral DNA incorporated within the host cell DNA by enzyme integrase. After forming this as one DNA, the virus is going to use the host DNA as the machinery for replication to make more copies. After forming many copies by the process known as replication, it is going to form what we call an mRNA. And this mRNA formed contains the strand for the host and the strand for the virus. So this one is going to move, this mRNA moves via the nuclear pore and goes where there is ribosome in the cytoplasm, where this DNA, this mRNA containing the viral and the host DNA undergoes translation in the presence of ribosome in the cell to form proteins. So it is translated to form new proteins. And this protein is always mature. These are called the paraprotein, which needs to undergo what we call post-translation modification. So after forming this long polypeptide chain commanded by messenger RNA from the virus, we are going to see an enzyme known as the protease. This protease enzyme is from the virus, the HIV virus. It is going to come and start cutting this paraprotein into fragments which are functionally active and structural, so that we are able to form the structural and functional smaller proteins which can undergo assembling by forming also the envelope. So they are assembled to form new virions. And after forming new virions, they are released from the cell by exocytosis or by budding. So the viruses are able to be moved, to be released, having their spikes with the genome inside. So the enzyme that catalyzes or that performs the breakdown of the proteins which are non-functional to functional proteins is known as protease from the virus, which enables, after breaking down, there is assembling and release of the virus so that the virus can go and attack new cells. So this is what we can see under viral replication, especially the HIV. And the important key points is the glycoprotein 120 binding with glycoprotein 41 with the co-stimulation of co-receptors CCR5 and CXCR4. After entering, it releases the viral RNA, which undergoes reverse transcription to form the DNA, which enters into the host cell, and in presence of integrase enzyme from the virus, it is incorporated to form one DNA, which undergoes replication to form many copies, then undergoes transcription to form an mRNA, which moves out via the nuclear pore to the ribosomes within the cytoplasm, which act as the machinery to form a longer polypeptide chain, which is cut by the protease from the virus to form structural and functional proteins, which undergo assembling to release the virus. So after understanding this, we are able to see where drugs act so that we can be able to prevent increase of the viremia. Because the main effect of this antiviral drug is not to treat the virus. They do not, but they help to reduce the viral load and also to prevent them attacking new cells. That is what we can talk about our aim. So we are going to see the first class of our drug. We are going to see which drug can prevent attachment of the virus, or what we call fusion. So there are drugs which can inhibit fusion of the glycoprotein 120 and glycoprotein 41. And this drug, we are going to call it emfavitide. We have a drug known as emfavitide. So emfavitide is a drug, and it is given by it is the only antiviral drug given by injection, especially subcutaneous, and its mechanism of action is to prevent fusion. For it prevents fusion of the HIV using glycoprotein 120 and glycoprotein. And when it fails to fuse, the virus cannot attack cells. Another drug we are going to use is the drug that targets the co-receptor, what we call the chemokine receptor. So we have seen one class is fusion inhibitors, and under fusion inhibitor, we have seen an example of a drug known as emfavitide, which is given by injection subcutaneous, and its mode of action or mechanism is to prevent attachment of the virus to the CD4 receptor. Then class number 2 is the chemokine receptor. Chemokine receptor antagonist. So chemokine receptor antagonist, this one, they act by binding and antagonize with the co-receptors known as CCR5 and CXCR4. These are receptors that enable firm attachment of the virus so that it can enter into the host cell. And the drug which is being utilized under here is known as maraviroc. Maraviroc is the drug which is being used for preventing or for antagonizing the action of CCR5 and CXCR4, so that there is no way how the virus can enter into the cell. And we're going to see that the discordant couples, people who cannot get HIV, they lack this co-receptor. This is CCR5. And without these co-receptors, the virus cannot enter into the cell. So they can have the virus in the blood, but cannot enter into the cells to cause the effect. Because we know viruses without the host cell, they cannot replicate. So maraviroc is helping us to prevent the entry of the virus into the host cell by breaking the co-receptors. And when they broke the co-receptors, the virus cannot enter. So we have seen enfavityde subcutaneous infection preventing attachment of the virus. Then maraviroc preventing or antagonizing with the effect of CCR5 receptors, and those drugs are being used. So from here, we might not prevent the virus to attach, we might not prevent it to enter into the cell, but when it has entered into the cell, we can easily say, let us prevent the viral RNA genome from being transcribed into viral DNA by blocking either competitively or non-competitively with the reverse transcriptase enzyme. So this one leads us to the third category of ART drug, known as NRTs. We are going to first look at NRTs, NRTIs, which are known as nucleoside stroke nucleotide reverse transcriptase inhibitors. Reverse transcriptase inhibitors. So this is the third category. And how do these NRTIs work? We are going to see that the nucleotide or nucleoside reverse transcriptase inhibitors, they work by competitively inhibiting reverse transcriptase enzyme, which converts the viral RNA genome to viral DNA genome. And how do they do it? That these NRTIs, they have what we call a dye. They employ a dideoxy nucleotide. Dideoxynucleotide. These drugs are taken as prodrugs. They are always taken as prodrugs, and they need to first be phosphorylated, whereby we add the phosphate group to form a trinucleotide. They are phosphorylated to form a triphosphate nucleotide. After being phosphorylated, their problem, this triphosphate lacks the OH group. At carbon number 3, it lacks the OH group, where we use to attach more nucleotide base during replication. So if I have the DNA, this is the template strand, and I have another strand which I'm synthesizing. This is from maybe 3' end to 5' end, is coming from 5' end. This is 3' end. At the 3' end, there is always a hydroxyl group. But dideoxynucleotides, for them, they lack this OH group at carbon number 3, where DNA polymerase can continue to add nucleotide bases which are complementary. So when I take this NRTI, once it is incorporated by the DNA polymerase, remember it is lacking the OH group. So there is no way how DNA polymerase can incorporate many nucleotide bases. So this one, because it is lacking the OH group, the drug, it is going to cause what we call premature chain termination. It causes chain termination before we synthesize the DNA which we wanted. So this is the mechanism of action of NRTIs. They are prodrugs which are phosphorylated in the body, and after being phosphorylated, they have or they lack OH group at carbon number 3. So they are dideoxynucleotides. So once incorporated with DNA polymerase during DNA replication, during DNA elongation, when incorporated, they lack the OH group at carbon number 3, which prevents more addition of nucleotide bases, leading to premature chain termination, and hence the virus cannot replicate. And examples of NRTIs include, we have tenofovir, we have drugs like zidovudine, we have drugs like stavudine, we have didanosine, we have example of drugs like lamivudine, we have emitriptyline. So these are some examples of the drugs which are NRTIs, whereby among all of them, only tenofovir is a nucleotide. This is a nucleotide, whereas the remaining ones are nucleosides. And this tenofovir is being utilized in combination in the first line for prevention of viremia and attachment to new cells. And its major effect is nephrotoxicity. Its adverse effect, it is known to cause nephrotoxicity and hyperpigmentation. It can cause nephrotoxicity and hyperpigmentation of the skin. So, meaning tenofovir is contraindicated in patients with renal failure or kidney disease. So if a patient is having disease condition known as renal failure, you're not supposed to give them tenofovir because it will cause more danger. And it is the only nucleotide which we have. Other drug is like zidovudine, and this zidovudine, for its major side effect is bone marrow suppression. This one causes bone marrow suppression, and it can lead to condition like aplastic anemia. It can lead to aplastic anemia. That's why currently it is not much in use due to its side effect on the bone marrow, which leads to what we call macrocytic anemia and decrease in all cell lines due to bone marrow suppression. Apart from that, it can cause hepatotoxicity, it can cause myopathy and neuropathy. But the major one is the bone marrow suppression. Then stavudine and didanosine, these ones are known to cause pancreatitis. They are leading causes of pancreatitis and myopathy plus hepatotoxicity. But the major peculiar side effect is pancreatitis when you're on stavudine and didanosine. Then lamivudine can also cause hepatotoxicity when taken, and this lamivudine is the one that is being utilized in all drug combinations of heart, highly active antiretroviral therapy, and it is known as 3TC. This one is known as AZT. Tenofovir is TDF. It can be TDF or it can be TAF. Then didanosine is DDI, and so many others as we shall see. So this is what we can discuss under nucleotide reverse transcriptase inhibitors, which we have seen they inhibit competitively reverse transcriptase enzyme by incorporating a dideoxynucleotide which lacks the hydroxyl group at carbon number 3, causing premature chain termination during DNA replication. Examples, we have seen tenofovir, which is the only nucleotide and it is known to cause nephrotoxicity, contraindicated in renal failure patients, whereas zidovudine causing bone marrow suppression, so contraindicated in people with anemia. Then stavudine contraindicated in people with pancreatitis and so forth. And these guys are being utilized to do many purposes in combinations of antiretroviral therapy. So the fourth class we can look at in this session is NNRTIs. NNRTIs. Non-nucleoside. Non-nucleoside stroke nucleotide reverse transcriptase inhibitors. So we have seen NRTIs were competitively inhibiting, but with non-nucleoside or nucleotide reverse transcriptase inhibitor, these are non-competitive. For them, they are non-competitive. And we have seen this drug, the NRTIs are pro-drugs, but these ones are not pro-drugs. We have seen NRTIs, they need to first be phosphorylated to a triphosphate. These ones, they don't need phosphorylation. And how do they do? If I have enzyme, if this is enzyme known as reverse transcriptase, and this is the active site, instead of the NNRTIs binding on the active site, they come and bind at the allosteric site. This is an NRTI. They bind on the allosteric site of the reverse transcriptase enzyme, causing a conformation change in the active site. So they cause conformation change in the active site. And when the active site changes, due to the allosteric binding of the NNRTIs, it leads to what we call, or it inhibits DNA replication. It is able to inhibit DNA replication. Because if I inhibit reverse transcriptase, I cannot form this viral DNA, which needs to be incorporated. And this viral DNA is formed during replication in the presence of also reverse transcriptase. So if I inhibit reverse transcriptase, I terminate the DNA elongation, hence preventing the virus from multiplying or to affect new cells. So that is its mode of action. And examples of drugs under NNRTIs include these drugs. They have in the middle, they have VIR. So in the middle, if you see any drug in the middle having VIR, you know that that is an NNRTI. And examples include nevirapine. It includes efavirenz. Efavirenz is another drug. Another drug we can talk about here is estraviline. Then also we have delavudine. These are examples of drugs under non-nucleotide reverse transcriptase, which non-competitively inhibit reverse transcriptase by binding to the allosteric sites. And we are saying in the middle, they have VIR in the middle. So that's how I can know that these are any NRTIs. And nevirapine is being used to prevent mother-to-child transmission. It can come as a syrup or a tab or tablets, but they are being used by HIV mothers who are breastfeeding by giving this syrup to children to prevent them from contracting HIV from their mothers who are seropositive. And that is the nevirapine which we are being utilized. Then efavirenz is also being used in the second line to dolutegravir. though its major effect is vivid dreams, because it causes hallucination, so you can end up having vivid dreams. Dangerous or nightmares, you can call them nightmares. And another thing, efavirenz is teratogenic. This guy is teratogenic. So meaning it is contraindicated in pregnancy. So it causes vivid dreams and it is teratogenic. That's why you cannot use it in pregnant mothers. That is efavirenz, being teratogenic and causing vivid dreams, or what we can call nightmares. Then another type we can have is estravilin and delaverdine, being used in treatment of HIV. So the major side effect, these drugs can also cause hepatotoxicity. They can also cause neuropathy by inhibiting mitochondrial DNA. But apart from that, efavirenz causing vivid dreams and being teratogenic. And that's why it is not so much commonly used as a first-line drug. But another news to tell you about this NRTIs, you see this non-competitive inhibition of reverse transcriptase is risky. So they are not so effective like others, and they have been replaced with dolutegravir. So DTG has replaced all the NRTIs because it is more effective than these drugs. Though you cannot give DTG to hyperglycemic patients. But if someone is not diabetic, DTG is better than using these NRTIs because it is very effective than them. So they have been replaced and they are of little use of current, though nevirapine still is being used to prevent mother-to-child transmission. So that is what we can discuss with you in this session. Hope you guys, you are enjoying this video. Continue to like, subscribe, and share to many others. So the second last type of drug we are going to use in this session is what we call protease. We are going to begin with integrase inhibitors. So we are going to have another type of antiviral drug known as integrase. This is number 5. Integrase inhibitors. These integrase inhibitors, for them, they target integrase enzyme. We remember the HIV virus comes with its own integrase, which incorporates the RNA DNA into the host DNA so that the host can become the machinery for replication of the virus. So this integrase enzyme, which is responsible for incorporating the viral DNA into the host DNA, we can use certain drugs that can inhibit this enzyme. And when I inhibit integrase, it means the viral DNA cannot be incorporated to host DNA. So it will be destroyed. And without being incorporated, the virus cannot replicate to form many copies, hence preventing increase in viral load. And examples of drugs under integrase inhibitor, they end with the suffix tegravir. And they are two commonly being used, that is dolutegravir, which you can abbreviate as DTG, and the second one we are using is raltegravir. So these are the ones which are currently commonly being used. But the commonly used is DTG, which has replaced any RTIs. But we said this dolutegravir, its major side effect is it causes hyperglycemia. So it is contraindicated in patients with diabetes mellitus. and it is always used in combination with lamivudine and tenofovir as the first-line drug in heart. So, but its major side effect, before you give the raltegravir, always measure the blood sugar levels so that you can rule out diabetes before you embark on giving your patient DTG, what we are calling the raltegravir, which inhibits integrase enzyme, preventing incorporation of the viral DNA into the host DNA. So that is what we can discuss with you under integrase inhibitors. The last class is protease inhibitors. And these protease inhibitors, they are so good. These are drugs which are very good. Protease inhibitors. And we said in DNA replication, viral replication, it has what we call protease enzyme. That after translation, it breaks down the paraproteins into structural and functional proteins which are assembled to form infective virion. So if I use a drug that targets and inhibits protease, I will form a paraprotein which is non-functional, and when assembled, it will form what we call non-functional viruses or non-infectious viruses. An example of these drugs under protease inhibitors include, we are going to see examples. These drugs, they end with the suffix navir. They end with the suffix navir, and they include ritonavir, lopinavir, and many others. So ritonavir, lopinavir are examples of these drugs which are under protease inhibitors, and their major effect, they are known to cause what we call hyperlipidemia. And we can also add other drugs like atazanavir. We can also add other drugs like saquinavir. And another example we left out under NRTIs is abacavir. Remember also abacavir belongs here. So always remember that abacavir, which is being utilized majorly in children, belongs to nucleoside reverse transcriptase inhibitors. But these are some of the examples of protease inhibitors, which ends with the suffix navir. Any drug that ends with the suffix navir and it is an antiviral, it belongs to protease inhibitors. And we've seen its major side effect. These guys can cause hyperglycemia, or we can begin with hyperlipidemia. So when you are on them, you can end up becoming obese or very fat because they increase the fat levels in the body. Another effect is they cause insulin resistance. And because of insulin resistance, they can end up causing diabetes mellitus. Another thing they can do is they also cause hepatotoxicity, and they can cause myopathy and rhabdomyolysis. So these are the side effects that majorly is hyperlipidemia and hyperglycemia due to increase in insulin resistance. So these are the classes of antivirals that we can discuss with you today. So as we finish this session, we want to see how do we combine these antiviral drugs? How can we combine to make sure we effectively treat our patients so that they don't increase the viral load and we don't continue destroying other new host cells? So there is what we call HAT, highly active antiretroviral therapy, which we are employing to make sure we treat our patients. Highly active antiretroviral therapy, which is a drug combination. in HIV drugs. And during this drug combination, first of all, it is not good we can combine either two drugs in one class, but you cannot make a combination with all drugs being in the same class. But we can combine one class with the other. And it is not always advised to do a combination of the same class, drugs in the same class. And the first line drug which is being utilized combination is TDF stroke 3TC stroke DTG, because we said DTG replaced the NRTIs. So you can always remember by saying TLD, whereby this is tenofovir, this is lamivudine, and this is dolutegravir. And it is being used as the first line in treatment of HIV. But if someone cannot tolerate TDF, in case of maybe they have renal failure, you can replace TDF with abacavir, ABC, or you can replace TDF with AZT, so long as someone is not having anemia. That is in case someone you cannot give TDF. And if this patient is hyperglycemic or is having diabetes mellitus, you can replace DTG with efavirenz, or you can replace it. In the first line we use efavirenz, but if it is the second line, we can use TDF stroke lamivudine stroke lopinavir stroke ritonavir. So this one becomes the second line. This is the second line treatment in HIV. Tenofovir, lamivudine, lopinavir stroke ritonavir. Ritonavir, its role, why we are writing it in small r, is to potentiate the action of lopinavir, and it is being used as a second line. But we said efavirenz, never use it in pregnancy. It is contraindicated in pregnancy because it is teratogenic. It has its own teratogenic effects. Then lastly, if we want to treat children who are HIV patients and they have kg below 20 kilograms, instead of giving tenofovir, which causes nephrotoxicity, we replace it with abacavir. Abacavir is the best drug being utilized in children with HIV, where you combine abacavir together with lamivudine, together with dolutegravir. Lamivudine is always constant, it rarely changes. So what can change is either the first drug or the third, due to underlying conditions, but lamivudine always remains the same. But if you cannot give abacavir, you can even give TAF. This is a form of tenofovir. You can also utilize it in children. And this is what we can tell you under highly active antiretroviral therapy. Then you can ask yourself, if you're treating HIV patients, maybe they abscond drugs and they get maybe a condition known as cryptococcal meningitis, what can you do? Or if someone has got TB, if it is a newly diagnosed patient, you find they have HIV, they have TB, what you do for the first 2 weeks, you begin by treating TB. Then either you can use amphotericin B, you can use rifampin, and after 2 weeks, you can resume with the first line, which is TDF 30C DTG. But if they are already on the ART and they get TB, what you do, you give the anti-TB drugs, continue with the regimen, and only double the dose of dolutegravir, because rifampin inhibits cytochrome P450, so which can cause to decrease in the dose. So you can double the dose of DTG. So this is what we can discuss with you in this session. Thank you so much for continuing learning with us at Medical Sciences by Naftali Muhumza. Hope you have enjoyed this video. Remember to like and share to many others. Thank you so much.